Hi everybody, thank you very much for joining us today for our first webinar of Webinar Week. We're very lucky to be joined by Lindsay Fowles and Kristina Ward, who are going to be talking a little bit about genetic counselling for inherited eye diseases. My name is Delaney and I'm part of the Program and Services team at the Macular Disease Foundation Australia, and I will be facilitating today's webinar. Before we move on, I would like to acknowledge the traditional custodians of the land on which we are meeting today and pay my respects to elders past, present, and emerging. Now, I would like to start off with some housekeeping. So if you can hear me and you can see the screen okay, that's great. That means you've been able to access the webinar. However, if you are having any sort of audio or visual problems, please try to refresh your screen and hopefully that will help. If that doesn't, then give our helpline number a call, which is 1-800-111-709, and somebody will be able to help you out. Now, you might be able to notice that your microphones and videos have been turned off. That is because we do have quite a few members in attendance today. However, that doesn't mean you can't interact with us. If you would like to send in some questions, you can definitely do that. And you can do that by clicking an icon towards the bottom of your screen. So you might be able to see a black strip at the bottom of your screen with a few different icons. The first thing you might be able to see says audio settings, and then towards the middle of the black strip, you can see a chat function, a raise hand, and a Q&A function. So if you click on the Q&A function, it will bring up a white rectangle, and at the bottom of the rectangle, you can pop in your question and then select send. If you would like to send your question in anonymously, you can do that by selecting the send anonymously box. However, just to let you know, only myself, Kristina, and Lindsay can see those questions. So no such thing as a silly question, just send them all in. Now, there is also another button you may be able to see towards the bottom of your screen, which is the leave meeting button. That will allow you to leave the meeting, so don't press that one just yet. All right, so that does bring us to the end of our housekeeping. Just to let you know, unlike our usual webinars, this webinar is only going to be half an hour in length, so we may be limited in terms of the questions that we can answer. However, if you do have questions, please send them through. We will try to answer as many as possible. If we don't get to your question, we will try to answer it after the webinar, and try to keep your questions quite general in nature if possible. So again, we do welcome you to our webinar for Webinar Week, our first one, which is going to be on genetic counselling for inherited eye diseases. And we're very, very lucky to be joined by Lindsay Fowles and Kristina Ward. So Lindsay Fowles is a Senior Genetic Counsellor working across a number of positions, including a lab-based role which supports non-genetic clinicians with ordering of genetic tests, a research role with KidGen, a national collaborative seeking to increase understanding of genetic kidney disease, and a clinical role with Genetic Health Queensland. The future of patient-centred care will involve embedding of genetic and genomic testing into standard clinical pathways, and Lindsay is keen to support clinicians in acquiring the skills and confidence to be involved in this work. We're also going to hear from Kristina Ward. Kristina is a person living with a disability. She was first diagnosed with Stargardt's disease about 15 years ago and has progressively lost central vision since. Stargardt's has made Kristina a more compassionate and mindful adult with a strength and resilience she didn't know she had. So thank you both very much for joining us today. I can't wait to hear what you both have to say.
And thank you so much for that amazing welcome. I'm really delighted to be here today. Just let me know if there's any problems with the audio, because as far as I'm aware, I've unmuted myself. I'm really delighted to be here today because one of my favourite things is talking to people about these conditions. I'm a genetic counsellor. I know about genetics, and I know the science behind it and things like this, but I'm just trying to make sure I'm getting a presentation as opposed to, I'm hoping that's better. But I don't know what it's like to live with these conditions. I learned so much from speaking with my patients and from talking to people who've been affected by these conditions. So I'm happy to talk to you about the science and the inheritance and all these sorts of things, but I'm really hoping to learn things today myself. So thank you for already covering the acknowledgement of country. Again, I would like to again acknowledge that our traditional lands and the owners, the custodians, and up in Brisbane where I am, it's a Yagara and Turrbal people. But of course, we have people from all around the country today, and I'd like to acknowledge the First Nations people who might be joining us. So what is genetic counselling? And really, it's all about communication. I'm not here, as a genetic counsellor, I'm not here to tell people what to do. Our goal is to support people to understand what they need to know, to appreciate what does their condition mean for them. So what are the medical impacts? What might be the impact of having this condition? You know, what's the psychological impact? What does it mean for their family? And when we start talking about families, then we also think about what does it mean for when they go to have their own children? So really, we're just helping people to learn and understand about their medical condition, what might be the genetic contributors to that, and having got that information together, making the best decisions for themselves. So these are the types of things we cover in a genetic counselling session. So to understand what happens for a condition, we want to know about their family history, and we want to know about that person's medical history. It helps us understand, is the particular condition in this family actually an inherited version of the condition? It'll give us an idea of what's the likelihood of the condition occurring again in this family? And if there's likely to be any genetic testing which can give some clarity around that. If we have clarity about the genetic components of the condition, helping a person learn about what that means. If we know what the inheritance is, what testing is available, a little bit about the management of the condition, though that's not really our area of expertise. And then helping those people make the right choices for themselves. We will not tell anybody what they need to do. It's really about supporting people in making the right choice for their personal circumstances. Now, I'm aware that we're speaking to people from across the country. I'm in Queensland. In Queensland, we do have a statewide genetic service, but that's not the case in every state. And the Macular Disease Foundation has done a lot of work putting together this awesome web page where they've actually put a genetic directory together. So if you go to their web page, you will actually see the local genetic services in your state. So I recommend they've done a very good job putting that together. Now, every state has a public health genetic service. There are more and more private services coming online. But if you do go to the public health service, and the public health services are all very good, you'll have no out-of-pocket expenses for your genetics appointment or testing if it's clinically indicated. Just to give you an idea of what happens in the public system, referrals generally have to come from a doctor, but that can be your GP or your specialist. The referral will be received, and there'll be an assessment of that referral. Not every referral will be accepted. They will have criteria by which they review their referrals, and there'll be an assessment of that. And once it's assessed, it'll be triaged, and that will determine the level of urgency for that particular referral, and that gives you the timeline to your appointment. That's just a vague overview, and I can't speak for the other services in other states, but that's roughly what happens in Genetic Health Queensland. But a lot of people go, I've been referred to genetic service. What are they going to do? They're going to stick things in me? What do they want to know? Do I have to get out my ancestry book? Do I have to know if I arrived with my family arrived with the convicts? You know, what do they want to know? What information needs to be gathered? And it's a really good question, because there is information that makes your genetics appointment, makes it much easier for us to do a more effective genetics appointment. And if it's possible, don't tie yourself in knots trying to gather this information, but if it's possible, if you can get information on about 3 generations of your family, that's ideal. But if you can't do it, that's fine. We work with the information we have. But I always say, I just keep asking questions till I run into a brick wall. Whatever you can give, that's fine. But not only do we want to know about family members who've had the condition, we also want to know about how many family members don't have the condition. We want to know roughly what was described as their diagnosis, roughly how old they were. How did someone make the diagnosis? Were they actually assessed by an ophthalmologist? Or has someone just said, oh yeah, Granny couldn't see when she went outside at night, someone always had to go with her? And most importantly, has anyone in the family already had genetic testing? And people, if they've had genetic testing and there wasn't an answer, often might mention that. So it's actually worth asking the question. The other thing is, why are you seeking a genetics appointment? What are the questions you want to have answered? Do you have a condition, or are you someone in the family who's unaffected and want to know if you might develop it? What are your questions? When you go to your appointment, they'll review that information you've gathered and look through your personal medical history as well. It's possible there might be an examination and your family history will be reviewed. If genetic testing is clinically indicated, then it will be offered to you. And there'll be a discussion around consent for that genetic testing. My son's just leaving, I'll just say the point. Consent's really important when it comes to genetic testing, because when we do genetic testing, it's not something that will impact only the individual who's having the testing. Genetics is something that's inherited, and so any result from a genetic test can impact not only on the individual having the test, but on their family members. And so that consent discussion is quite important, and it must be documented. Test is on a blood sample, and that initial diagnostic genetic testing usually takes up to 6 months. If you're an unaffected person who's attending for an appointment and you want to know if you might develop the family condition, we'll go over that family history information. Has someone in the family already had genetic testing? Has the genetic cause for the family condition been identified? And this is what I've just referred to. Is there consent to use that result? Because sometimes someone in the family has had genetic testing, but either for whatever reason, consent has not been granted to use that result, or consent has not been documented. And that's where we run into it can be tricky. There may have been an intention by that individual for consent, for that result to be used for family members, but the consent has not been documented. We can only offer genetic testing to an unaffected individual to see if they might develop the family condition if the genetic cause of the family condition is already known. So this is why someone in the family might say to a person who does have the condition might say to them, say, can you go to the genetic service and have testing? We know you've got the condition. Because sometimes people say, why do I need genetic testing? I know I've got this. And it's to facilitate testing for other family members. Now, I've talked about that. Better consent discussion is really important. It's important that it's voluntary and that you know what you're consenting to. And really, we need to consider not only what the result might be, and I'm going to talk now, in a moment, I'm going to talk about what the potential outcomes from genetic testing can be, but also thinking about the emotional impact and just some more pragmatic things like insurances and things like that. I'm not going to go into that in detail now. Talking about consent is a whole half-hour talk in and of itself, but there are things that you should consider. I'm going to talk a little bit about the results and the possible results from genetic testing. So when we're talking about genetic testing, the thing we focus on is that there are three possible outcomes. And just as a quick overview, when we do genetic testing, what we might find as a result of that genetic testing is we find nothing. The situation is the situation we're in now. We know that there's a condition in the family, but we don't know what's causing it. A variant of uncertain significance or a pathogenic mutation. So nothing's identified. Why didn't we find something? And it might be that there's a very clear family history. The clinical picture is such that we know that this is an inherited condition. Surely we would have found something. But there are reasons why sometimes we don't. Sometimes we're looking at the testing has focused on the wrong genes, or the genes that are involved in this family's condition haven't been discovered to be involved in that condition yet. Maybe we use the wrong technology. There are different types of mutations, and so sometimes you have to use a specific type of technology. And sometimes you do see things happening in a family, but it's not due to a specific individual gene change, and it's because there's a whole bunch of things that run. It's what we call a multifactorial condition. And families share more than just inherited single gene factors. They can share environmental factors as well. They share diet, they share interest in exercise, they share smoking behaviours. So sometimes it's not because it's a single gene genetic factor that's causing the condition. It's because the family has multiple risk factors that are predisposing them to a particular condition, and we can't find that with a single genetic test. Sometimes we do get an answer, yay. Well, I think yay. Not everybody thinks yay. Sometimes this is difficult information to receive. But one of the bonuses of finding an answer is we have clarity. We know what the inheritance is. We know exactly what the condition is. We know how it's inherited, so we know which other family members might have the chance of being affected by the condition. And those family members can have genetic testing to clarify if they will or won't develop the condition. If members of that family wish to, and this is a very personal choice, if it was important for them and they wanted to follow this path, they could have options in pregnancy and make choices that would result in them avoiding having a child affected by the condition. Our third option, and this is the most difficult one to explain, it's what we call a grey zone result. So finding something and finding nothing, we call that black and white. It's very clear, black, white. Then we have this grey zone result, a variant of uncertain significance. Now we're very, very good at using big words to explain for something simple. Variant of uncertain significance. A variant just means we found something a bit different. uncertain significance just means we don't actually know what it means right now. And when you think about it, we are all human. We all have the same 20,000 odd genes. And we are all different. Every single one of us, same 20,000 genes, and we are, every single one of us, apart from identical twins, different. So there is a huge range of totally normal differences in those 20,000 genes. Now, sometimes when we do genetic testing, we find one of those differences, and it's one we haven't seen before, and so we know it's a difference, a variant. We don't know what it means. So at this point in time, it just means we don't know if it's benign, so normal, or it causes disease, pathogenic. It's not halfway in the middle. It could be completely benign, or it could cause disease. But the reality is, at this time, we don't have enough knowledge to understand which bucket it falls into. Is it a normal difference, or is it a disease-causing difference? So those are our three options: the black, the white, and the grey. We find nothing, in which case we're in exactly the same situation as when we started. And this is why it's really important to start with someone in the family who clearly has the condition. Because even when we start with someone who clearly has the condition, sometimes the genetic testing can't find the underlying genetic factor. We find an answer, a pathogenic mutation. Pathogenic just means we find the mutation or the gene difference that causes the disease. And that means we have clarity and understanding, and there are options available. Or we find a variant of uncertain significance, which we refer to as a BOO, because we love an acronym. And it just means at this time, we don't understand what it means. Notice my focusing on at this time. And we'll ask you to come back to us in 2 or 3 years' time and say, have you learnt more? Because we're learning more all the time. And in 2 or 3 years' time, we might be able to tell you if that variant of uncertain significance is benign or pathogenic. And actually, the majority of BUSs turn out to be benign. There is another possible outcome, and this is with our development of the technology where now we can test lots and lots and lots of genes all at once. In the past, we used to just test 1 or 2 genes at a time, and then we sort of started testing more. And sometimes now we'll even test quite a lot. We do try to keep our testing focused on the genes that are very closely related to the condition that we're interested in. But sometimes we're not so sure, or we use a gene test that incorporates quite a lot of genes. And so sometimes we get a result which is not related to the original question we asked. It actually is a change in a gene which isn't related to the original clinical picture. And it's really important you ask questions about this type of possible outcome if you have genetic testing. Ask the doctor or the genetic counsellor, what is the chance of there being an incidental finding? And they might say, oh, we're only looking at 25 genes that we know are tightly associated with eye conditions like yours, and it's very unlikely we'll get an incidental finding. Any gene change we pick up is going to be connected with your eye disease. Or they'll say, well, actually, we're looking at 150 different genes, and it's possible we might find something that has a relationship to a slightly different condition, and they should talk about that when they do the consent. So just remember to ask about that. I think you'll find that most testing will be focused very tightly on eye conditions. So, but it's just something to flag. And when I'm talking too fast. When I was thinking about talking to a patient group, and wondering about what is it they would really want to know in a genetics talk. And what comes up quite a lot are the options for family planning. And we need to remember too that making very active choices in pregnancy or for reproductive choice is very definitely not for everybody. And that's what genetic counsellors do. We provide you with the information. We tell you what is possible, and we help you explore what's important to you. What's your ethical position? What's your religious position? And then help you work out what is the best choice for you. And so I just wanted to flag here that for a family where there is a genetic condition, these are some of the possible choices. And doing nothing is always an option. This is what's been happening in families for generations already. And, you know, in some families, you know, there are people who are inheriting these conditions, and you learn to live with it and you manage it. And this is just, you know, and for some families that I've spoken with, you know, they go, well, what's the big deal? This is just, you know, all families have challenges, and this is just a challenge that our family deals with. For other families, they say, well, it's not something I want to pass on, but I'm not interested in making any of those choices, or the genetic factor that causes the condition hasn't been identified, and they might choose to use sperm or egg donation, depending on whether it's being inherited from the father or the mother's side. For families where the genetic mutation or the genetic cause for their family condition has been identified, and they want to make choices to actively avoid having a child affected by the condition, there are options available to them. Now, that third band, prenatal testing, that's when they fall pregnant as per the standard way. I'm not going to explain that. But, you know, fall pregnant naturally, and then they have testing in the pregnancy. And so there's a couple of times during the pregnancy at which you can have direct diagnostic testing of the baby, of pregnancy, CVS at around 11 weeks, or an amniocentesis at around the 16-week mark. And that can give you direct genetic information about the pregnancy. And if the pregnancy is found to be affected by the family condition, then they're left with the choice of deciding whether to continue that pregnancy or not. So you're considering whether you might have a termination of pregnancy. For others, they make the choice to go through IVF, and that's where the pregnancy is achieved using, you know, the test tube and a baby in a test tube type techniques. So this is especially when a couple has fertility problems and they're already having to go through IVF. They may say, well, we're going through IVF anyway, we'll just add on this extra step for pre-implantation genetic diagnosis. And the goal here is to achieve a pregnancy with an embryo which is not carrying the familial genetic factor. So to achieve a pregnancy with an embryo that won't develop the familial condition. Just flagging that this is not an easy path, and for couples where there is no fertility problems, there is no guarantee that they will get pregnant via this pathway. There's no easy path to an unaffected pregnancy when the genetic factors are known. These are all challenging pathways. And I would recommend that anyone who's considering these pathways, that they go and get experts. So having come off that very serious topic, we'll just like to make things a little bit more lighthearted. A reminder that genetic testing is not straightforward. Some people have this expectation that genetic testing, it goes into this machine and then this straightforward answer just gets spat out at the other end. Its analysis of this data is incredibly difficult. And this, I'm a bit of a nerd and I like XKCD, and I think they, this cartoon just says it all. It is not easy to analyse your test results. Please don't give your scientists a hard time if they cannot get an answer out of your genetic testing. So I'm hoping you've had enough time to look at that cartoon now, and I'm really looking forward to hearing from Kristina because, as I said, I don't live with a genetic condition. I learn so much from hearing from people who do, and I'm so looking forward to hearing Kristina speak now. So thank you, Kristina, for coming on today as well.
Thanks, Lindsay. That was really, really interesting and informative. So thanks very much. And good afternoon to everyone, and thanks for joining us. My name's Kristina, and I have Stargardt's disease, which is a genetic form of macular degeneration with no known cure or treatment. It affects about 1 in 10,000 people, which, to put it into some context, means there's about 2,600 people in Australia with the disease, and I'm one of them. I am a person with a disability. It took me years to admit that, even to myself, and even longer to actually be able to say it out loud. I found it confronting, emotional, and scary, but I suppose with age and maturity and acceptance of my disease, I'm now comfortable to say it and admitting it. I'm a person with a disability. My Stargardt story doesn't start until about 15 years ago, so in that respect, I'm fortunate. I'd been wearing glasses and been short-sighted since my early 20s, so I was very used to going to the optometrist regularly. I had 2 very young children, and I went to the optometrist just for a routine eye checkup. I knew my eyesight had deteriorated. I could no longer see the trees on the leaves on the trees, sorry, being clear and sharp, and things were just a little bit blurry, even with my glasses on. So I figured I just needed an increase in my glasses, but I was very, very wrong. The optometrist couldn't get my eyes to focus, and so sent me to an ophthalmologist who had a look at my macula and then referred me to a retinal specialist. Since I'd never seen an eye specialist or anything before, I had no idea what to expect, and the whole process was really quite frightening and foreign to me. No one explained why I was there for so long or why I was taken into different rooms and had so many different tests on lots of different machines. Nothing was explained to me, and I was there for hours. And at the end of the appointment, I saw the retinal specialist. He wrote the word Stargardt on a post-it note and handed it to me. He told me I would go blind, but it wasn't that bad because I would retain my peripheral vision, but progressively would lose my central vision and would be legally blind. He told me that I should come back in 12 months and to look up Stargardt on the internet because there's lots of information there. He had no compassion or empathy and little bedside manner. He's not my specialist anymore. I did go back after 12 months. I didn't really know where else to go or anything. And that experience was nearly as traumatic as the first, so I never went back again. But after leaving his rooms the first time, I was scared and shocked and bewildered and really quite scared about what my future would hold. After I went back the second time and didn't go back, I kind of put my head in the sand a bit, I suppose, and I didn't see a specialist for a few years. It wasn't until my optometrist called me and told me that she had met another retinal specialist from near my area at a conference and thought I should go and see him, so I did. He was fantastic. He was very supportive, and I saw him twice, And after that, he put me in touch with one of his colleagues who was more involved and more experienced in genetic eye disease. And I've been seeing her ever since. She's kind and caring, and I can ask her anything, and I feel very, very comfortable going and seeing her. She was the one that sent me to have genetic testing, and the genetic counsellors that I went to were supportive and informative and explained the genetics behind my disease really, really well, that I then went and explained to my family members so that we all understand it. And I'm really, really pleased that I went and had it done. I think finding the right medical practitioner for you is vitally important. I was 33 when I was diagnosed with Stargardt's, and I'd been driving since I was 17. I stopped driving at night pretty much straight away, as my night vision really wasn't that great. But apart from that, for the first couple of years, having the disease didn't really change my life very much, and things kind of just went on as usual. I knew at some stage I would have to give my driver's license up altogether, and I hoped that I could get to the stage where both of my children were in primary school before I had to stop driving, just to make things easier. After a couple of years, my marriage broke down, which I knew was going to make things even trickier, and then my youngest started school. I stopped driving in November of 2012 when she was at the end of kindergarten. I gave up my licence voluntarily as I'd noticed a deterioration in my eyesight, and I was very aware that every time we got in the car, I had 2 young children in the car that I was responsible for. I thought that giving up my licence would be the tipping point for me, and that I would lose the independence that driving gives you, but it wasn't. It was a Sunday morning, quite wet and dreary for November. I put the kids in the car. We drove up the peninsula near where I live. We played on the sand. I took photos of them in the car. We had a sunroof, so they popped their heads out of the sunroof and we took photos, and then we drove back to home. As we got closer and closer to home, my eyes welled up with more and more and more tears. So by the time I pulled into the driveway, I really was crying a lot. The kids didn't really know why, but that was the last time I would ever drive a car. 10 years later, and looking back, it's a really, really precious memory to have, but it wasn't easy at the time. Since I grew up not knowing that I was a person with a visual impairment, and for the first 33 years of my life not knowing anything like that, I took things for granted. Not intentionally, but I did. Putting makeup on, realising what coins are in your purse, being able to see the numbers on an approaching bus, being able to read a price tag when you're shopping, sewing on a button, reading a recipe or reading a book, all of these things I now need assistance or assistive technologies to do, and I no longer take them for granted. I miss seeing things that I used to be able to see using my sight. A pod of dolphins in the surf, a bird in a tree, the facial expressions of the people sitting around me. They're things that seem really, really small, but they do really mean so much. Macular degeneration is often depicted as a black hole in the middle of an image. Now, everybody is completely different, but for me, it looks nothing like that. The best way I can describe it is if you imagine that you are painting a picture, and before the paint dries, you get your fingers and you smear the paint from the outside of the picture towards the middle of it. So whatever was in the middle of that picture just kind of disappears, and the colours and everything from the outside of the painting kind of all smear into the middle. So then it's not like a black hole, it's just like a blur in the middle. That's what I see. I'm really, really lucky enough to be surrounded by family and friends who help and support me when I need them and live in an area that's accessible with good services. My mum has been and continues to be a rock that supports us immensely. I can't tell you how many times she has driven us to soccer training or to a soccer game in the pouring rain and freezing cold on a Saturday morning early, or to a dance concert or dancing lessons or swimming lessons or doctor's appointments. There are just so many things that she has done for us to make things easier. I know that I am strong and independent, but being a person who is visually impaired creates challenges that are sometimes sad and hard to deal with. Not noticing that it's your son that kicks the goal on the soccer field, not being able to see your daughter smile when she's dancing on stage during her concert, not being able to get in the car and pick your teenagers up from a party at night, or duck up the road to get milk and bread because you realise you've run out and need it for the morning, can all be quite confronting. But I make a conscious effort every day to see, pardon the pun, the glass half full and appreciate everything that I have. I'm very conscious, and I know that there are people around me who have much greater challenges than I do. I am a person with a disability, and that's my story so far. Thank you.